evening to all. Today I will be talking on a topic which is for us more important for us clinicians with what we see in our day-to-day practice. I will mainly talk about the gaps in our guideline and what are the modifications we need to do in specific patients like this. So this is just a prototype patient like we see in our day-to-day practice, like a 68-year-old male, non-diabetic patient, currently on basal insulin along with oral anti-diabetic agent, known patient of CKD, and patient already had an DKA maybe 2 to 3 years back. With the past recent history, patient is having mild fever with lethargy and a little bit of nausea and persistent vomiting for last 3 to 4 days. And as the patient was not being able to eat, and the patient himself has discontinued the insulin, now came to our emergency with a shortness of breath and pain abdomen. So with this in the background, in the ear, so they did the basic evaluation of the patient. The patient is already having pedal edema, heart rate maybe around 110 with a BP of 140/70 and a saturation of spirit of 88. The neck also involves chest, the grapes are there. And in labs, the CBG is 386. ABG, there is evidence of metabolic acidosis with an anion gap of 24, potassium is 4.9, creat we get a little bit later with an 4.5, uncontrolled hyperglycemia, influence of 11.3, urine examination, albumin plus, ketone body 2 plus with a parcel of around 10 to 12, the point of care, the echo screening revealed the EF of 35% with no descent or decline. So with this background, so what can be our working diagnosis and how we are going to manage this patient. So this type of patient is not very rare in our clinical practice, and we all know we have a set guideline for diabetic ketoacidosis set by different authorities like British Diabetic Guideline. Also we have a combined guideline from ADA. However, we cannot manage this patient if we go by the guideline in detail. So what are the modifications we need in our patient, specifically if this patient is having this situation, that is my agenda for today's talk. Like in comorbidities, like the patient with CKD or heart failure or acute coronary syndrome as Sarah suggested, or the patient with pancreatitis, in special population which needs special care, like our geriatric population or in pregnant patient. And now we are seeing different atypical presentation of DKA also, like with the use of SGLT2 inhibitor, the risk of glycemic decay and also the overlap of DKA and hyperosmolar state. So DKA in chronic kidney disease like in this patient, so almost 7.5% of the patient we get admitted in DKA, they are having end-stage renal disease, and this patient they have a higher rate of complications like increase in the hospital stay, higher readmission rate, increase in the mortality as well as increase in the hypoglycemic rate. The problem of this patient is that from the presentation point of view also, that this nausea, vomiting, acidotic breathing, sometimes we think it is because of renal failure per se rather than the decay, and the classical features of decay like dehydration is sometimes absent because there is a lack of osmotic diuresis in the patient of CKD, and that's why dehydration or volume depletion is not common. Perhaps they can present with hypervolumia. This patient has higher risk of hyperkalemia because of there is again risk lower renal function as well as the persistent metabolic acidosis. They have a higher glucose level, hyponatremia and hypophosphatemia. So if you look from the basic diagnosis point of view, we mainly rely on these 3 parameters for the diagnosis of DKA. One is hyperglycemia, one is ketosis and one is metabolic acidosis. Now for the CKD patient, the hyperglycemia sometimes we can miss because in most of the CKD patient now, specifically in diabetic patient, we use SGLT2 inhibitor which can lead to glycemic decay. So we need to be cautious. Metabolic acidosis, whatever we find in our patient, that can be due to pre-existing metabolic acidosis because of the renal failure per se, because both of these will cause high amount of metabolic acidosis. And ketosis sometimes, like in this patient, may be due to prolonged fasting or maybe due to repeated vomiting or because of the use of drugs. So in this background, that's why it is very difficult in our day-to-day clinical practice to give a pinpoint diagnosis. However, if you look in the literature, mostly we consider the diagnosis of DKA in the background of CKD, if the iron gap is a little bit higher, like it is more than 20 milliequivalent per liter, or after therapy, like retrospectively, if the fall of iron gap after insulin therapy is more than 5 milliequivalent per liter. Or another thing that is very important, that we measure the serum, that blood ketones, mainly the beta hydroxybutyrate. If it is high, more than 3, then mostly we consider this is a patient of DKA in the background of CKD. And we need to deviate from the standard set guideline in this group of patient, because in case of euphonic CKD, as there is lack of dehydration, we do not recommend that initial bolus as we recommend in the standard guideline management for DKA. And if we need a very strict and continuous hemodynamic monitoring of the patient, if we found the patient to be hypovolemic only, then only the IV fluid is given in a small aliquot of around 250 ml per time, and it has to be given slowly. The standard insulin infusion rate, like that a fixed rate IV insulin therapy that we give in DKA patient, that has to be also reduced to around rate of around 0.05 unit per kg per hour, rather than the standard dose, specifically in those patients who are already in A30, or in those patients having low glucose of less than 250, or if the fall of glucose is more than 50 mg per dl per hour. Routine supplementation of potassium is not recommended, and normally we do not give bicarb whenever you are managing any DKA patient, unless the patient is hemodynamically very unstable and the pH is less than 6.9. But however, in some of the guidelines they have recommended, or they have said that it can be used in case of pre-existing chronic metabolic acidosis due to renal dysfunction if the pH is less than 7.2, only in this background. Now, DKA in heart disease is another area where we have to be very cautious, because we all know that diabetes per se will increase the risk of different heart-related conditions, mainly the acute coronary syndrome as well as the heart failure. For DKA and SAS, which causes which, it is very difficult to diagnose. So it is a classical example of chicken and egg conundrum. And sometimes the classical symptoms of diabetes is based in heart failure patient because of the use of diuretics, and this coexistence of a heart failure and diabetes is very difficult to diagnose clinically, because there is a paradoxical intravascular volume depletion along with peripheral edema, and DKA per se can increase the cardiac enzymes, mainly the troponin. So these are, for these overlapping reasons, it is very difficult sometimes to get a pinpoint diagnosis. Again, for treatment purpose, this DKA with heart failure, it is we need to balance the fluid management very carefully, because there are two fundamentally opposing management protocols. In one side, DKA wants this aggressive fluid management, on the other side, we usually restrict fluid for the heart failure. So that's why an invasive hemodynamic monitoring like that IVC and arterial line sometimes we need for the proper intravascular volume status, and very cautious and sole replacement of minimal fluid bolus is needed in this patient. And sometimes, if the patient is the BP, the blood pressure is low, it is not because of intravascular volume depletion, but because of the heart failure per se, and we need vasoactive agent rather than IV fluid for managing this patient. And hypervolemic patient, those who are having low glucose, we need to sometimes use concentrated glucose like 25 mg rather than 5 mg or 10 mg, just to reduce the volume load in this patient. We should not forget to find the precipitating cause like infection, diarrhea, stress, which can precipitate a cardiac event as well as DKA in this patient. And we need to modify the chronic medication, specifically SGLT inhibitor, if used in this group of patients. Another area like a little bit less common, however, that need to some discussion, that is DKA along with pancreatitis and along with hypertriglyceridemia, which can precipitate pancreatitis. This is referred in the literature as a enigmatic triangle, and they have shown higher mortality rate and high risk of multi-organ failure in this group of patients. Again, the symptoms are sometimes overlapping, because pain, abdomen and vomiting that can present both as a features of acute pancreatitis as well as DKA, and DKA per se can increase the serum lipase and serum amylase, again making the diagnosis difficult. And delayed diagnosis or missing any of these two can lead to drastic consequences. However, treatment-wise, a little bit is the protocol-wise, the treatment usually doesn't differ, and we need the early fluid replacement and concurrent management of acute pancreatitis. Use of IV insulin is helpful to further rapidly reduce the increased triglyceride level in this group of patients. So these are the common comorbid conditions where we need modification for the management of DKA. Coming to the special population like in elderly or geriatric patient, again the management is difficult because in geriatric patient there will be multiple comorbidities like CKD, heart failure, and the increased risk of in-hospital mortality, prolonged hospital stay will be more in this group of patient. Another problem is that with the geriatric patient is that they are relatively asymptomatic. The presentation for DKA sometimes can be simple neurological presentation rather than a GI symptoms, and sometimes the precipitating factor, precipitating cause like an infection, sepsis may be remain unnoticed because of the marked features. There can be sepsis without fever, so that's why our clinical eye should be very wide open so that we do not miss the precipitating factor. The management point of view in elderly patient, again we need to be very cautious for the rate of fluid replacement, and usually we follow a little bit of restricted approach until and unless patient is very frankly dehydrated. Some guideline has recommended balanced steroid solutions to reduce the risk of hyperchloremic non-anorexia metabolic acidosis. However, these solutions are more hypotonic. That's why the chance of cerebral edema is higher. So there is still some gray area related to this. If the patient have developed an AKI or hypovolemic renal dysfunction, then we need to modify the other drugs which the patient is normal home medication, and we need to be cautious. And again, the concurrent treatment of precipitating factor, most commonly infection in this age group is very much important to prevent further domino effect and the degradation of the patient. DKA in pregnancy is an unique area where we need to save two lives. One is the mother's life, and another is the unborn child's life. And DKA present with this acidosis and high maternal osmolarity, which is a very detrimental for fetus, and the risk of fetal demise in DKA is much higher. In another way, we need to be very careful not only for the management of the mother but also for the survival of the fetus. Pregnancy perhaps is a ketogenic state because of the increase in the insulin resistance because of the placental hormone, accelerated starvation, and that's why DKA precipitated in the lower glucose level in pregnancy, and it progresses also more frequent, more rapidly. Mostly in today's world, we see the DKA mainly in the type 1 patient in pregnancy, and for this reason we need to be very careful from the prevention point of view, because in pregnant patient for the lung maturation we have gynecologists use this prophylactic steroid, and that time we need to increase prophylactically the patient's usual dose of insulin, or we need to shift the patient to the variable rate insulin infusion. And for the patients specifically type 1 diabetic patient, those who are going the trial of normal labor, administration of carbohydrate and concurrent insulin therapy is very much important during the active labor also. Otherwise, because of the prolonged fasting and lack of insulin, it can precipitate a episode of DKA, specifically during labor, because it is a very high stressful condition for the mother. So for the treatment of DKA in pregnancy, we need to be very cautious for the early recognition, immediate hospitalization, and concurrent management by the obstetrician as well as the physician. And management is more or less similar to the non-pregnant patient with an aggressive fluid management and insulin. We should look for the precipitating factors also, like the prolonged vomiting and intractable vomiting in case of hyperemesis gravidum in the early part of the pregnancy, and for the late pregnancy, like mostly more than 24 weeks of gestation, the fetal monitoring is must and it should be done properly. Now lastly I will discuss for one or two atypical forms of DKA. One is the euglycemic decay. So that means there is a diagnosis of decay. However, the glucose is less than the expected level, and we call it euglycemic if the CBG is less than 250 mg per dm. And these are the common causes of decay, of which ketogenic diet, pregnancy, SGLT2 inhibitor use, alcohol ingestion, these are the common that we see in our day-to-day clinical practice. And in this group of patients, we should be very cautious, specifically if the clinical symptoms of suggestive of decay, a mere lower glucose does not excuse the patient does not have a decay. SGLT inhibitor, because of multiple mechanisms, by increasing the glucagon level and increasing the ketogenesis from liver as well as reabsorption of the ketone bodies from the kidney, they have a higher risk of ketoacidosis. And usually, as this SGLT inhibitor causes renal glycosuria, the presentation is usually euglycemic rather than hypoglycemic. And among these patients now, whatever in the recent series they have seen that in the patient who are presenting decay in the elderly in the hospital, almost 10% they are attributed to the use of SGLT2. And for prevention of this euglycemic decay, the guidelines say that whenever the patient is having some elective surgery or an invasive procedure, the SGLT2 inhibitor should at least be stopped at least 24 hours before surgery, and we should not stop or reduce the dose of insulin during that time. And regularly, like this patient who are on SGLT inhibitor, we should discourage the diet which is very low in carbohydrate or like ketogenic diet. We should have a high clinical suspicion, and a glucose less than 250 mg per day should not be used to exclude decay, specifically in this high risk group of patient. In the patient who are already diagnosed as a euglycemic decay, the management is to discontinue SGLT2 inhibitor or other precipitating factor. Basic principle of treatment remains same. However, in this group of patient, as the glucose is on the lower side, so we need to use the fluid as a dextrose containing fluid, either 10D or 5D, and sometimes we need to reduce the FRI rate, and we need to continue the FRI till the ketosis is corrected. And there are different protocols specifically for those patients who are of type 1 DM who uses SGLT2 inhibitor to prevent the precipitation of euglycemic decay, like the stop decay protocol, which is qualitatively we can decide the amount of extra carbohydrate the patient has to take along with insulin to prevent if there is an occurrence of ketoacidosis. The basic concept is that in this group of patients we have to give both carbohydrate along with extra insulin to suppress ketogenesis. Until and unless we give glucose, that carbohydrate in this group of patients along with insulin, the ketogenesis will not be corrected. There are other protocols like switch protocol, which says in the patient with type 1 diabetes, if we are suspecting ketoacidosis, so we should stop the SGLT2 inhibitor if the patient is already on, because and we need to add additional bolus insulin, as well as we need to give free sugar or oral carbohydrate, and we need to give proper hydration for prevention of any episode of euglycemic decay. Another atypical form is the overlap between decay and the hypervascular state. Normally in elderly patient, in the case series it has been shown that up to 30% of patient has been seen to having features of both decay and hypervascular coma, and it is usually diagnosed with the features of decay, like there is marked hypovolemia, hyperketonemia and metabolic acidosis, along with features of HHS like severe hyperglycemia and increased serum osmolarity. From the management point of view, in this group of patients, they usually require more IV fluid and aggressive hydration rather than the decay. And on the other hand, if you compare with the management protocol of HHS, in this group of patients, the insulin should be started early, like we start in decay with a higher rate of around 0.1 unit per kg per hour. In the case series, it will say that this overlap group have a typical presentation of initial hyperkalemia. After that, after initiation of insulin, there is a tendency to go for the hypokalemic range. So that's why in this group of particularly this group of patient, like frequent monitoring of potassium and proper management for this electrolyte imbalance should be done. So now coming back to this patient is elderly and this patient is having multiple comorbidities. We have our working diagnosis of DKA because this patient having the features of DKA as well as the amine gap was very high, it was around 24 on the background of a CKD and heart failure and probably neurosepsis. We do not know because we need to have some other pending investigation. The line of management is mostly that we should stabilize the patient, go for proper hemodynamic monitoring. We should be a little bit guarded when we are giving this IV fluid, and the rate and the type of IV fluid should be determined by the hemodynamic monitoring and the blood glucose level. In this group of patient, because this patient is already having heart failure, if the BPS is not improving even after proper hydration or intravascular volume checking, then we need to think of adding vasoactive agent rather than giving more fluid. IV insulin as per the protocol, however, a little bit of lower side dose because the patient creat is very high. Electrolyte monitoring is very much important, and we need not to forget the treatment of precipitating factor. Mostly here is an neurosepsis, and we should do the proper antibiotic as per the institutional infection control protocol, and we need to modify the home medication accordingly, specifically if the patient already on a SGLT inhibitor, because patient is already having ketoacidosis as well as patient is having neurosepsis. So, to take home message that management of DKA is a common thing in our day-to-day practice, but we need to remember that one size does not fit all, and there is impact of comorbidity. Specifically, we face real-world challenges that we face as a clinician rather than following the guidelines in a full complete manner. We need to modify treatment according to our need of the patient. High suspicion for diagnosis is very much important, and patient in special population like elderly, pregnancy, patient with comorbidity, we need to modify our treatment protocol, and we should not forget to search and treat the precipitating factors. Thank you for your patience. Hearing these are the references I can follow.